Thank you, Ronaldo. So, on behalf of my co-investigators, I'm pleased to be here. The PRESERVE trial, as Ronaldo indicated, was a trial of contrast-associated AKI. It was a multinational randomized controlled trial that was designed to compare the effectiveness of isonatric sodium bicarbonate to isotonic sodium chloride, and to evaluate the efficacy of N-acetylcysteine for the prevention of major adverse kidney events and death following coronary and non-coronary angiography. Most studies of contrast-associated AKI have focused on interventions to prevent the short-term change in kidney function associated with contrast administration. On the other hand, what we're really trying to prevent are the longer-term consequences of the episode of AKI, namely accelerated progression of underlying kidney disease, need for dialysis, and the increased mortality. So we designed the PRESERVE trial with interventions that we were hoping would alter the development of the short-term development of AKI, but our focus was really on decreasing the longer-term outcomes, which we assessed at 90 days. The inclusion criteria for the study were patients undergoing coronary or non-coronary angiography who we assessed to be at high risk based on underlying kidney disease. So these were patients who either had stage 3B or stage 4 CKD with an eGFR of 15 to 45, or patients who had stage 3A CKD, an eGFR of 45 to 60, with concomitant diabetes mellitus. Patients also needed to be able and willing to provide informed consent. A long list of exclusion criteria, exclusion for patients with more severe kidney disease, so stage 5, CKD, patients with unstable serum creatinine, decompensated heart failure, in which it would, was felt by the treating physicians that it would be unwise to give the protocol required fluids. Patients requiring emergent angiograms, such as a patient with an ST segment elevation MI, because of the concern that the randomization procedure would actually delay required treatment. Patients who had received iodinated contrast within the prior 5 days, patients with known severe allergies, either to N-acetylcysteine or iodinated contrast, and then the usual other exclusions for clinical trials. The interventions, this was designed as a 2x2 factorial design. The study fluid, patients were randomized to either receive 1.26%, which is 150 millimole per liter sodium bicarbonate, or 0.9% sodium chloride, with a semi-protocolized approach to fluid administration. So patients received 1 to 3 milliliters per kilogram per hour of fluids over 1 to 12 hours, with a total infusion of 3 to 12 milliliters per kilogram. Now, this sounds very confusing, but it actually was a relatively simple approach, because we stratified whether a patient was inpatient or outpatient. So inpatients received 1 milliliter per kilogram per hour of study fluid for 6 to 12 hours pre-procedure. Outpatients received 3 milliliters per kilogram over 1 hour pre-procedure. During the procedure, patients received between 1 and 1.5 milliliters per kilogram per hour of their study fluid. Post-procedure, again in the semi-protocolized approach, 1 to 3 milliliters per kilogram per hour over 2 to 12 hours for a total infusion of 6 to 12 ml per kilogram. Again, stratified by inpatient or outpatient status. So inpatients, again, received 1 milliliter per kilogram per hour for 6 to 12 hours. Outpatients, we initially specified 1.5 milliliters per kilogram per hour over 4 hours. As over the duration of the study, there was a greater use of radial artery approach for coronary angiography, and the cardiologists were getting patients out sooner. We allowed patients to receive as much as 3 milliliters per kilogram per hour for 2 hours to get the total infusion of at least 6 milliliters per kilogram. All weight-based infusions were capped based on a maximum weight of 125 kilos. For the N-acetylcysteine, patients received either 300 milligram capsules of N-acetylcysteine or a matched placebo, given with 4 capsules 1 hour pre-angiography, another 4 capsules 1 hour post-angiography, and then the same 1,200 milligrams, 4 capsules twice daily on days 2 through 5 for a total of 5 days of therapy. Our primary outcome was a composite of death within 90 days, renal replacement therapy, or a persistent decline in kidney function at day 90, defined by a greater than 50% increase in serum creatinine. If they hit that increase, it was then confirmed within 14 days with a second creatinine assay. Secondary outcomes included AKI at day 3 to 5, death within 90 days, renal replacement therapy within 90 days, the persistent decline in kidney function, hospitalization for ACS, heart failure, or stroke within 90 days, and all-cause hospitalization within 90 days. Sample size was calculated based on the assumption of an event rate in the saline placebo group of 10%, an absence of interaction between the two interventions, a postulated 25% effect size, 3% loss to follow-up. So with 90% power, using an alpha of 0.025, splitting the alpha between the two interventions, we needed a sample size of 7,680 patients. Just a little bit on the timeline of the study. This was handled through the United States Department of Veterans Affairs Cooperative Studies Program, which has a somewhat unique funding mechanism. So we were approved for protocol planning in March of 2009. The first protocol was reviewed in 2010 for scientific review. They didn't like our endpoint, which was a 25% increase in serum creatinine at 90 days, so they had us revise it to the 50% increase. It was reviewed and approved in January of 2011. We included colleagues from the George Institute in Australia. They obtained independent funding, and they initiated enrollment of February of 2013. We weren't approved by the administrators to begin enrollment in the U.S. until October of 2013. The plan was to complete the study within 2.5 years, but as often happens, things moved slower. Enrollment was slower than planned. We had our planned midpoint interim analysis in September of 2016, and based on the results of that analysis, we had requested an extension of funding so we could complete our enrollment, but the VA sponsor chose, based on the interim analysis results, to have us close enrollment in March of 2017, and the study closed in September of 2017. So this is the complicated consort diagram for the study. We enrolled a total of 5,177 patients. There were a number of patients who did not undergo angiography after randomization. We excluded patients who didn't undergo angiography and never received study drugs. So our primary analytic cohort was a modified intention to treat cohort of 4,993 patients, distributed. So this just shows the 4 cells of bicarbonate and acetylcysteine, bicarbonate and placebo, sodium chloride and acetylcysteine, sodium chloride and placebo. The first thing we did was we analyzed to make sure there wasn't an interaction between the two treatments, which there was not, so that we could analyze based on the individual interventions, so bicarbonate versus sodium chloride and acetylcysteine versus placebo. So baseline demographics shown here, the four separate interventions, bicarbonate versus sodium chloride and acetylcysteine versus placebo. There was no difference in terms of the demographic characteristics other than a slight overrepresentation of Hispanics in the sodium bicarbonate group. Clinical characteristics were extremely well balanced between the interventions as shown here. Procedural characteristics were also very well balanced. We had anticipated a 1/3, 2/3 split between coronary and non-coronary, and we actually had about 90% of the procedures as coronary angiography. Percutaneous interventions were done in slightly over a quarter of the patients. The contrast agent used in slightly more than half of the patients was the isoosmolar iodixonol, with all the other patients receiving low osmolal agents. The median volume of contrast material was 85 ml. And in the patients who had a left ventricular and diastolic pressure measured, it was around 18 in all patients. So let's look first at the outcomes for sodium chloride versus sodium bicarbonate. So we have shown here the primary endpoint and the various secondary endpoints. For the primary endpoint, the rate was 4.4%. In sodium bicarbonate, 4.7%, with sodium chloride for an odds ratio of 0.93, not statistically significant. And I will point out that the lower bound of the 95% confidence interval was greater than 0.7, which means that if you were to analyze this as a non-inferiority trial for sodium chloride, this would pass a 30% non-inferiority bound. For all the secondary outcomes, also results were non-significant, so contrast-associated AKI. In fact, the trend was the opposite direction, 9.5% with bicarb, 8.3% with sodium chloride, but also highly non-significant. As I said, all the other outcomes, death, need for dialysis, the persistent change in kidney function, hospitalization for cardiac cause, or all-cause hospitalization, all non-significant. This is the pre-planned subgroup analyses. On this panel, we have the primary endpoint. In this panel, we have the AKI at 3 to 5 day out point. And you can see that none of the subgroups had any imbalances in outcome other than here, where non-coronary angiography was associated, the sodium chloride was associated with a statistically better outcome, although given the small sample size and the fact that we have multiple comparisons, we don't attach much significance to this and think that this is really just a statistical aberration and not a clinically meaningful difference. In terms of the N-acetylcysteine, so now we're looking at the groups pooled, the about 2,500 patients who got N-acetylcysteine versus placebo. And again, primary endpoint, 4.6% with N-acetylcysteine, 4.5% with placebo, odds ratio of 1.02. Again, non-significant, and again, if you look at this in terms of non-inferiority, it certainly fits a 30% non-inferiority bound. And the same is true for all the other endpoints. For the AKI at 3 to 5 days, 9.1% with N-acetylcysteine, 8.7% with placebo. Again, the trend in the wrong direction for the active agent, but not statistically significant. Subgroup analyses completely balanced in all subgroup analyses, both for the primary endpoint and for the AKI endpoint. So our conclusion is that IV sodium bicarbonate is not more effective than IV sodium chloride for prevention of either the MAKE-D or AKI endpoints following angiography, and N-acetylcysteine is not effective either for these two endpoints. Now, an interesting observation that I just want to point out here. So of the 4,993 patients, we had 8.9% with AKI, 91.1% without AKI. And then of those patients, 11.9% of the patients with AKI went on to the 90-day outcome as compared to 3.8% of the patients without that 90-day outcome. But if you look at the absolute numbers, it was actually more patients without AKI who had that outcome. In fact, only 23.4% of the 90-day events occurred in patients who had sustained AKI. So this actually points out an issue with the MAKE-D endpoint that we need to think about in future trials. So if this is our conceptual model, interventions to prevent contrast-associated AKI, reduce the episodes of AKI, and reduce MAKE-D, we need to bear in mind that the risk factors for contrast-associated AKI are also risk factors, independent risk factors for the 90-day outcome. In addition, there are intervening events. It should come as no shock to anyone that if you have a cardiac cath, you are more likely to end up in the OR within the next 30 days having cardiac surgery, or if you're having peripheral angiography, having major vascular surgery. So intervening events, which may also contribute to these outcomes and may also contribute to development of AKI. So I want to conclude by acknowledging the large team that participated in this study, in particular Steve Weisbord, my colleague at the University of Pittsburgh and the Pittsburgh VA, who was the study chair, and Martin Gallagher, who led the effort through the George Institute in Australia, and Jim Kaufman, who was the study director. And to acknowledge the many sites that participated in the study in the United States, Australia, New Zealand, and Malaysia. And with that, I thank you for your attention.